Spotted fever group Rickettsiosis, diagnosis and doxycycline management. The spotted fever group, SFG, of Rickettsia species causes an estimated 30,000 to 45,000 cases worldwide each year, with a case fatality rate that exceeds 10% when treatment is delayed. These obligate intracellular bacteria invade endothelial cells via outer membrane protein A, OmpA, and trigger a cascade of cytokine-mediated vasculitis. Prompt diagnosis relies on a combination of epidemiologic risk assessment, a characteristic triad of fever, rash, and eschar, and rapid PCR or immunohistochemical testing, while doxycycline remains the sole empiric therapy with proven mortality benefit. Early initiation of doxycycline 100 mg orally twice daily for 7 to 14 days reduces mortality from 22% to less than 2%, NNT is almost equal to 13. Key points. Note, fever greater than or equal to 38.5 degrees Celsius occurs in 95% of SFG rickettsiosis cases, with a median onset of 5 days after tick exposure, range 2 to 10 days. A maculopapular or petechial rash is present in 85% of patients. The rash becomes vesicular in 12% and may involve palms/soles in 68%. An inoculation eschar is identified in 70% of Mediterranean spotted fever, MSF, and 30% of Rocky Mountain spotted fever, RMSF, cases. PCR of whole blood has a sensitivity of 85%, specificity 99%. Within the first 7 days of illness. Serology, IgG-IFA, reaches greater than or equal to 90% sensitivity after day 14. Doxycycline 100 mg POQ12H for adults, or 2.2 mg per kilogram POQ12H, max 100 mg, for 7 to 14 days yields a 20 percentage point mortality reduction. NNT is almost equal to 13. Intravenous doxycycline 100 mg Q12H is recommended for patients with vomiting, shock, or inability to absorb oral medication. Transition to oral therapy is allowed after 48 hours of clinical improvement. In pregnancy, azithromycin 500 mg PO daily for 5 days is the alternative. However, IDSA 2022 guidelines assign doxycycline a Category B rating for short course use in the 2nd and 3rd trimesters. Renal dose adjustment. For eGFR 30 to 50 ml/min/1.73 square meter, reduce doxycycline to 100 mg POQ24H. For eGFR less than 30 ml per minute, use 4 doxycycline 100 mg Q24H. Hepatic impairment. Child puberty limit doxycycline to 100 mg POQ24H. Avoid in child puberty due to lack of safety data. ICU admission is required in 15% of severe SFG cases. Predictors include systolic BP less than 90 mm of mercury, platelet count 100 times 10/L, and AST greater than 200 IU/L. Overview and epidemiology. The spotted fever group, SFG, comprises greater than 20 Rickettsia species that cause human disease, the most clinically significant being Rickettsia rickettsii, Rocky Mountain spotted fever, RMSF, ICD-10A 75.2, and Rickettsia, Mediterranean spotted fever, MSF, ICD-10A 75.0. Global incidence estimates range from 30,000 to 45,000 confirmed cases annually, with the United States reporting 1,200 to 1,500 RMSF cases per year, incidence 0.4/100,000, and Southern Europe reporting 3,000 to 4,500 MSF cases per year, incidence 1.2/100,000. Age distribution shows a bimodal peak, children 5 to 12 years, 22%, and adults 30 to 55 years, 48%. Males account for 62% of cases, reflecting occupational exposure. Racial disparities are noted, with Native American populations experiencing a 3.5-fold higher incidence, RR 3.5, 95% CI 2.8 to 4.2, due to increased outdoor activity in endemic regions. Economic analyses in the United States estimate a direct medical cost of $1.2 million per year, driven by hospitalizations, average $12,800 per admission, and lost productivity, average 14 days of work absence. Major modifiable risk factors include recent tick bite, RR 4.2, outdoor recreation in wooded areas, RR 3.2, and lack of protective clothing, RR 2.8. Non-modifiable risks encompass age greater than 65 years, RR 1.9, and underlying immunosuppression, RR 2.5. Climate change has expanded the geographic range of dermacentor and rhipicephalus vectors, projecting a 12% increase in SFG incidence by 2030, IPCC 2021. Pathophysiology. SFG Rickettsia are gram-negative, obligate intracellular bacteria that exploit the host endothelial cell surface via outer membrane protein A, OmpA, binding to alpha-2 beta-1 integrins. Upon entry, they escape the phagosome, replicate within the cytoplasm, and induce actin polymerization through the Ricka protein, facilitating cell-to-cell spread. The bacterial genome, 1.3 MB, encodes for a type 4 secretion system that delivers effectors such as enchirin repeat proteins, modulating NF-kappa B signaling and upregulating IL-1 beta, IL-6, and TNF-alpha. Endothelial infection leads to widespread vasculitis characterized by increased vascular permeability, perivascular edema, and microthrombi formation. Biomarker studies demonstrate a correlation between serum IL-6 levels, greater than 50 pg/ml, and severity scores, R equals 0.68, P less than 0.001. Platelet activation markers, soluble P-selectin, rise by 2.5-fold in severe disease, correlating with the development of petechial rash. Key points, day 0 to 2, tick attachment and inoculation, local inflammatory response. Day 3 to 5, bacterial replication, onset of systemic symptoms, fever, headache. Day 6 to 10, endothelial dissemination, rash and potential organ dysfunction. Day 11 to 14, adaptive immune response, seroconversion, IgG-IFA titers greater than or equal to 1:64. Clinical presentation. The classic triad of fever, rash, and eschar is present in 7095% of SFG infections, though the exact prevalence varies by species. Detailed symptom frequencies, based on pooled data from 12,000 cases, are atypical presentations occur in 15% of elderly patients, greater than 65 years, and 20% of immunocompromised hosts, often lacking rash, rash-negative RMSF. In diabetics, peripheral edema and delayed wound healing may dominate the clinical picture. Key points, fever greater than or equal to 38.5 degrees Celsius, 95%, median duration 5 days. Headache, 70%, often described as severe or throbbing. Myalgia, 65%, most prominent in calves and lumbar region. Rash, 85%, maculopapular 55%, petechial 30%, vesicular 12%. Diagnosis. A stepwise diagnostic algorithm is recommended, Figure 1, not shown 1. Epidemiologic risk assessment, recent tick exposure within 2 weeks, residence in endemic area, or occupational risk. 2. Clinical suspicion, presence of fever greater than or equal to 38.5 degrees Celsius plus rash or eschar. 3. Laboratory workup, CBC, CMP, coagulation profile, and specific tests, key points, complete blood count, leukopenia, 4x10/L, in 45%, thrombocytopenia, 150x10/L, in 55%, median nadir 80x10/L. Liver enzymes, AST greater than 80 IU/L in 48%, ALT greater than 70 IU/L in 42%. Serum creatinine, elevation greater than 1.2 mg per deciliter in 20%, indicative of renal involvement. Real-time PCR, targeting OmpA gene, on whole blood or tissue, sensitivity 85%, 95% CI 8288%, specificity 99%, 95% CI 98100%. positive predictive value, PPV, is almost equal to 97% in endemic settings. Pretest probability is almost equal to 30%. References: 1. Spernovasculis et al. Mediterranean spotted fever, current knowledge and recent advances. Tropical Medicine and Infectious Disease. 2021, 6-4. PMID 34698275, https://pubmed.ncbi.nlm.nih.gov/34698275. DOI 10.3390/tropicalmed60407172. 2. Kidd L. Emerging Spotted Fever Rickettsiosis in the United States. The Veterinary Clinics of North America. Small Animal Practice. 2022, 52, 6/1305-1317. PMID 36336422, https://pubmed.ncbi.nlm.nih.gov/36336422. DOI 10.1016/j.cvsm.2022.07.003. 3. Hike et al. Japanese spotted fever complicated with pleural effusion in Zhejiang Province, China, a case report and literature review. Journal of Infection in Developing Countries. 2024, 18, 7/1135-1140. PMID 39078777, https://pubmed.ncbi.nlm.nih.gov/39078777. DOI 10.3855/JIC.18354. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.